Hello everyone, welcome back to this series of lectures in hepatology. Today we will be discussing another very important topic, which is your acute hepatitis and your drug-induced liver injury. So let's begin. So acute hepatitis, as the name suggests, is basically inflammation of the liver, right? So acute hepatitis basically refers to inflammation of the liver, right? So what are the various etiologies for acute hepatitis? So the various etiologies include, most importantly and most commonly, is your viral hepatitis. So there are viruses which are hepatotropic, which cause damage to the liver and cause inflammation of the liver. This includes hepatitis A, B, C, D, E, and your cytomegalovirus, herpes simplex virus, and Coxsackie viruses. So all of these hepatotropic viruses can result in acute hepatitis. Then drugs and toxin. Drugs and toxin is a very important cause and under-recognized cause of liver damage, right? So there are a huge number of drugs which can cause liver damage that we will be looking at in detail a little further on. Very important toxins that you should remember. One, very easy, alcohol, very common. Then the other toxin includes poisoning such as mushroom poison, right? Amanita phalloides, mushroom poisoning, or even rat poison. Okay. Then the third most important etiology is your ischemic hepatitis. Ischemic hepatitis or congestive hepatitis, where the hepatitis occurs mainly due to right ventricular failure or heart failure. Then autoimmune hepatitis, though the percentage is less, this can also result in acute hepatitis. Then you have disorders of copper metabolism. Copper metabolism, inherited disorder of copper metabolism, is your Wilson's disease. Then you have your HELP syndrome. Where have you heard this HELP syndrome? You would have heard it in OBG. This is nothing but hemolysis, elevated liver enzymes, and low platelet count. So this HELP syndrome is basically seen which is one of the important causes of acute hepatitis. HELP syndrome is a type of thrombotic microangiopathy. Okay, it's associated with eclampsia. So these are about, in general, the wide various causes for acute hepatitis. So firstly, we will be looking at the various viruses which cause acute hepatitis. Most importantly, we will be looking at hepatitis A, right? So two viruses which we will be studying under this, which are clinically important, is your hepatitis A and hepatitis E. Hepatitis B and C have a predisposition to chronic hepatitis. They become chronic hepatitis and cirrhosis. So that we will be learning separately, right? So we'll start off with hepatitis A. So the hepatitis A virus is basically a single-stranded positive sense RNA virus, right? So amongst the hepatitis viruses, almost all are RNA viruses except your hepatitis B, which is your DNA virus. So this is a single-stranded positive sense RNA virus. Okay. How is it inactivated? It is inactivated by boiling for 1 minute, use of formaldehyde or UV rays. Okay. The transmission of the hepatitis A virus is via the fecal-oral route, right? So it is basically acquired via the fecal-oral route, contaminated food and water. Okay. So how do you prevent this, right? So it is inactivated by boiling for 1 minute, formaldehyde and UV rays. So always drink well-boiled water, because there is increased risk of transmission of not only hepatitis but lot of other organisms such as your E. coli, your cholera, and so on and so forth. Okay. The incubation period is about 3 to 4 weeks. So once this hepatitis A enters the body, it takes about 3 to 4 weeks for the symptoms to appear. So hepatitis A is a single-stranded positive sense RNA virus. It is transmitted by the fecal-oral route. It has an incubation period of 3 to 4 weeks, in fact 1 month, and it's inactivated by boiling and UV rays. So what are the clinical features? The most importantly, you remember that every acute hepatitis is usually heralded by a prodromal phase. So there are 3 phases in acute hepatitis. You have a prodromal phase, you have an icteric phase, and you have a recovery phase. So during the prodromal phase, what do they have? They can have fever, they can have myalgia, they can have joint pains, right? So they have fever, myalgia, joint pains, lot of constitutional symptoms like fatigue, anorexia, they are unable to eat, they have a lot of nausea, vomiting, right? This fever is often a low-grade fever and you can have multiple arthralgias as well. Okay, so this prodromal phase usually lasts for around 1 week. After the prodromal phase, within 5 to 6 days or even up to 1 week later, you can have an icteric phase. So the icteric phase, icterus is basically jaundice. So this is characterized by jaundice. So followed by the prodromal phase, you have the icteric phase where they have jaundice. Okay. So in this jaundice phase, what happens is that there is yellowish discoloration of the body, and that is when they begin to notice it and they appear to the clinical care facility. So you will have yellowish discoloration of the sclera, you can have yellowish discoloration of the palms and soles. You can have yellowish discoloration of the body as well. Apart from that, you can have on examination tender hepatomegaly. Because of the active virus replication, they can be tender hepatomegaly. Splenomegaly is rare, but you can still have it. Okay. This phase again lasts for about a week or so, followed by which they enter the recovery phase. So we have the prodromal phase, then you have the icteric phase and the recovery phase. In this recovery phase, what happens is that the AST ALT levels begin to drop. So whenever there is damage to the liver, what happens? The AST ALT levels will get elevated. So the AST ALT levels begin to drop, though the AST ALT levels can be elevated for a prolonged period of time. Symptomatically, they become better. They start eating well. And the fever is gone, the anorexia is improving, and the jaundice also begins to decrease. The bilirubin levels also slightly begins to decrease in your recovery phase. Okay. So this is about the clinical features. Now let us look at the lab features. So what are the laboratory features of hepatitis A? So there is elevated AST ALT TB. Apart from that, in the CBC you can find neutropenia, you can find lymphopenia. Sometimes they can be associated prolonged prothrombin time as well, right? So let us look at the graph here. So the first thing is that whenever there is infection with hepatitis A virus, there will be fecal shedding of your hepatitis A. So in the initial stages, there is from 0 to 4 weeks. This is your timeline in weeks. From the initial stages, which is your 0 to 4 weeks, the fecal hepatitis antigen testing can help in the detection of hepatitis A virus. Okay. After 4 to 8 weeks, there is IgM anti-HAV. So there are antibodies formed against this hepatitis A virus. So IgM is the first one which rises, followed by IgG, which comes later. So the initial testing is your IgM anti-HAV, which usually occurs about in the period of 4 to 8 weeks and starts dropping after your 8th week. So during this phase, your ALT remains elevated and your total bilirubin remains elevated, after which it begins to fall. So the recovery usually starts from 12 weeks, right? About 10 to 12 weeks later, the recovery starts and your IgG is detectable at that time, right? A very important thing and a good thing about hepatitis A is that it generally does not go into chronicity. It does not go into carrier state. So it's not like someone becomes a carrier and they keep shedding hepatitis A. It does not grow into chronicity. It does not grow into carrier state. So it does not have a risk of cirrhosis or hepatocellular carcinoma. So there is no risk of cirrhosis and there is no risk of HCC with hepatitis A. Sometimes around 0.1% of the times, hepatitis A can also go into fulminant hepatitis. Okay, it can go into fulminant hepatitis where they can have massive liver failure with multi-organ dysfunction, renal failure, hepatic encephalopathy and so on, but that is a rare complication. Other complications include, you can have a relapsing pattern of hepatitis A virus, right? So they can have frequent relapsing pattern and sometimes you can also have a cholestatic pattern. The treatment for hepatitis A is most often conservative, right? It's conservative. You treat them with good IV fluid support, give them parenteral nutrition, keep them well hydrated. Most of the times recovery is the rule. Prevention, we have a vaccine which is called the Havrix vaccine. Havrix is a recombinant vaccine which can be given to patients who have high risk of hepatitis A, for example, healthcare workers and so on, or animal handlers or people working in the food industry. So, or if they are traveling to a hepatitis A endemic region. So, these patients you can have a vaccine given to them. So this is about your hepatitis A. Now let us look at the next virus, which is your hepatitis E virus. Okay. So this is also a single-stranded positive sense RNA virus. Incubation period is 5 to 6 weeks, and again similar to hepatitis A, the transmission is fecal-oral route. So this is also inactivated by boiling for 1 minute, formaldehyde and UV rays. The clinical features are very similar to your hepatitis A. It has a prodromal phase, it has an icteric phase, and it has a recovery phase. Your laboratory evaluation can again show elevated AST, ALT, total bilirubin, direct hyperbilirubinemia, prolonged PT, neutropenia can be present. Okay. The risk, again, this risk of chronicity and carrier state is absent in hepatitis E as well. But the most important features of difference that you have to remember about hepatitis E versus hepatitis A is that the fulminant hepatitis risk is much higher. It's about 1 to 2%, right? Especially in pregnancy. The risk of hepatitis E virus causing fulminant hepatitis is much higher. Okay, and it causes a cholestatic pattern as well. Again, the treatment of hepatitis E is also conservative in nature, and you have recombinant vaccines for prevention. Okay, so this is about your hepatitis A and your hepatitis E virus. Now let us look at the next very important cause of acute hepatitis, which is your drug-induced liver injury. DILI basically stands for drug-induced liver injury. Okay. So drug-induced liver injury is one of the most important causes and very under-recognized cause of liver injury. So liver injury that occurs after the consumption of a drug or toxin, and it is characterized by ALT levels more than 5 times the normal without symptoms, or ALT levels more than 3 times the normal with symptoms, along with total bilirubin elevation 2 times the normal after the initiation of the drug. Okay, so after the initiation of the drug, now maybe it can happen immediately, sometimes it can happen after 1 week, sometimes can happen after 3 to 5 days. So there can be nausea, there can be vomiting, anorexia, jaundice. So all of these features happen because of damage of the liver by the drug. Biochemically, how do you define it? ALT elevation more than 5 times without symptoms, right? Asymptomatic ALT elevation more than 5 times, or symptomatic ALT elevation more than 3 times along with total bilirubin levels more than 2 times. Isolated total bilirubin is not considered to be DILI. Okay, there should be evidence of hepatocellular damage. Sometimes the drugs can also cause a cholestatic pattern, right? They can call a cholestatic pattern of liver injury. So after the initiation of the drugs, if the ALP levels have become more than 2 times the normal. So normal levels are 40 to 140, right? So if it has become maybe around 200, 300 after the initiation of the drug, then this is your liver injury. So the most common cause all over the world for drug-induced liver injury is your paracetamol, right? Is your paracetamol. So paracetamol poisoning happens when the dose is more than 25 gram per day, right? So in this paracetamol poisoning, there is loss or depletion of glutathione and it can result in profound liver failure. Most common cause in India, however, is your anti-tubercular drugs or your ATT. So the most common cause for drug-induced liver injury in India is your ATT. In the world, it is your paracetamol. So let us understand some of the mechanisms of drug-induced liver injury. So the drugs can basically have a direct toxic effect, or it can be a idiosyncratic reaction. Direct toxic effect basically means that whenever you were doing your drug testing, you knew that there are chances of drug-induced liver injury. So there is a predictable reaction to the drug. And this is a dose-dependent process. So there is a predictable reaction to the drug and it is dose-dependent. In your idiosyncratic reactions, this is unpredictable, dose-independent, and it is characterized by fever, rash and eosinophilia. So this is about the two mechanisms. You can have direct toxic injury or you can have idiosyncratic drug reactions. Fine. Now let us look at the mechanisms. So what is this diagram showing you? This is your hepatocyte. Right? This is your hepatocyte. So the first mechanism is that the drug can basically cause disruption of your cytoskeleton. Right? So the drug can basically cause disruption of the cytoskeleton and membrane damage resulting in blebs of the hepatocyte. There can be blebs on the membrane of the hepatocytes and rupture, which causes injury. Second, drugs can cause cholestatic hepatitis. So in this cholestatic hepatitis, what happens is that there are bile duct canaliculi, right? So the bile duct canalicular membrane can get damaged and there can be damage to the transporters in your bile duct, Fine. The third mechanism is that they can form adducts with your cytochrome P450 enzyme, right? So they form drug adducts like this. So these drug adducts basically cause stimulation of your cytotoxic T cells. It causes stimulation of your cytotoxic T cells. So when these cytotoxic T cells are stimulated, they basically go and damage your drug adduct complex. So when the drug adduct complex is attacked, it in turn causes liver injury. Okay? So that is your third mechanism. Fourth mechanism is that whenever there is a damage to the hepatocytes, it can result or trigger your apoptosis by itself. So it can trigger apoptosis and there can be activation of the Fas-Fasl ligand or programmed death cell ligand, and there can be apoptosis of your hepatocytes. Fifth, there can be damage to the mitochondria. And there can be increased production of reactive oxygen species. There can be damage to the mitochondria, increased production of reactive oxygen species, and oxidative damage to the liver. Okay? So these are about the various mechanisms by which the drugs can cause liver injury. Now let us understand a very important concept, which is your Hy's law. So Hy's law is a very important concept, and Hy was basically a person who devised this concept to ensure that the drugs that come out into the market are safe to use and do not cause very severe liver damage, right? So this basically states that whenever you're doing clinical trials for a particular drug, if jaundice occurs in the phase 3 clinical trial of a drug, then it is more susceptible to liver injury, right? So if there is jaundice occurring in the phase 3 clinical trial, that means that if the drug is continued, there are 10:1 higher chances of it causing drug-induced liver injury. So this is what the Hy's law states. So whenever you are doing your clinical trials of the drug, you always watch out for jaundice during the clinical trials and ensure that the liver safety profile is established. Then another very important concept is your concept of R ratio. R ratio basically refers to the ALT is to ALP ratio. So this ratio is basically used to find out what sort of pattern of damage is the drug causing. So if the ratio is more than 5, it is suggestive of a hepatocellular pattern. If the ratio is more than 5, it is suggestive of a hepatocellular pattern, and less than 2, it is suggestive of a cholestatic pattern. Okay. Now, let us move on to the various morphologies which you can find in the liver biopsy in the different types of drug-induced liver injury. Now, let us move on to the various types of morphologies you can find in liver biopsy on the various types of drug-induced liver injury. So, first is your cholestatic pattern. So, in which drugs cause your cholestatic liver injury? You have to remember anabolic steroids, estrogen, carbamazepine. Carbamazepine is basically an anti-epileptic. This causes what is called as your vanishing bile duct syndrome. Okay. The other drugs include your antiplatelet like clopidogrel and ezetimibe, which is your anti-dyslipidemic drug. So these are the group of drugs which can cause cholestatic pattern of liver injury. Very importantly, you remember estrogen, you remember carbamazepine. Fatty liver is basically when you on biopsy, if you do a biopsy, you find fat-laden cells, right, with the nucleus pushed over to the corner and a vacuolated appearance. So what are the drugs which can cause fatty liver? you have amiodarone, tetracycline and valproate. Then viral hepatitis pattern. Viral hepatitis pattern is basically characterized by diffuse inflammatory infiltrates into the liver. So very importantly, your antitubercular drugs INH, rifampicin, antifungals, ketoconazole and your ART medication zidovudine. All of these are basically associated with a viral hepatitis pattern. Then mixed pattern is seen with amoxiclav. Necrosis, very important. You have your acetaminophen, carbon tetrachloride, yellow phosphorus and mushroom poisoning. Acetaminophen, carbon tetrachloride, yellow phosphorus and mushroom poisoning. Then which are the drugs associated with granuloma formation in the liver? Granuloma is seen with quinidine, allopurinol. Which drugs can cause vascular injury? Vascular injury means they can cause a Budd-Chiari sort of syndrome. This is your anti-cancer drug, which is melphalan. Okay, so this is actually a little bit of memory based, but if you just go through and remember the prototypic drugs, then it will become very easy. Now, what about the management of drug-induced liver injury? So what about the management of drug-induced liver injury? So whenever you are suspecting a drug-induced liver injury, you will have to definitely stop the offending drug. Stop the offending drug, right? It depends on how much injury has happened. Is the patient presenting with just hepatitis or is the patient presenting with fulminant hepatic failure? For example, whenever there are drugs which cause necrosis, right? Like for example, paracetamol poisoning, mushroom poisoning, they present with fulminant hepatic failure. So the management of fulminant hepatic failure we will be looking into. If they are presenting with acute hepatitis, you stop the affecting drug, and you use conservative measures, right? You see for the complications of acute liver failure, right? If they are developing renal failure, if they are developing hepatic encephalopathy, you treat them accordingly. But if it is just hepatitis, then you stop the drug, you manage them conservatively, and you serially monitor the LFT and see for improvement. Okay? So this is about your drug-induced liver injury. Now we move on to your acute liver failure or your fulminant hepatitis. Okay? So what is this acute liver failure or your fulminant hepatitis? So whenever there is an encephalopathy or coagulopathy which occurs within 7 days of your inciting event, whenever there is hepatic encephalopathy or coagulopathy which occurs within 7 days of an inciting event, it's called as hyperacute liver failure, and if it occurs within 7 to 28 days, then this is called as acute liver failure. Alright? So what is the most common cause? The most common cause of fulminant hepatitis, you would be surprised to know, is hepatitis E. This is in the world. What are the other causes? So more or less anything that causes acute hepatitis has the propensity to cause fulminant hepatitis as well. So other causes includes hepatitis B, other viruses like CMV, HSV, very important drugs. We have just looked at the huge list of drugs which can cause liver injury and fulminant hepatitis. Then Wilson's disease can present as fulminant hepatitis, right? Then autoimmune hepatitis. Then vascular disorders like Budd-Chiari syndrome and HELP syndrome. So what is the basic difference between acute hepatitis and fulminant hepatitis? In fulminant hepatitis, you can have serious complications such as encephalopathy and coagulopathy. Alright, now let us look at the clinical features. So how does acute fulminant hepatitis present? So they basically present with fatigue, nausea, vomiting, loss of appetite, right? So whenever this patient presents with fatigue, nausea, vomiting, loss of appetite, and then they begin to rapidly deteriorate, they become extremely sick, right? So they can develop features of hepatic encephalopathy, where you have altered sensorium, We'll be looking at hepatic encephalopathy more in detail in your chapter on chronic liver disease. And you can have coagulopathy, you can have elevated PT-INR, APTT. Okay? Then apart from liver failure, you can also have ensuing renal failure and they can develop sepsis with MODS. Okay, MODS is multi-organ dysfunction syndrome. So acute fulminant hepatitis is a very dangerous situation and they deteriorate very rapidly. So in this situation, initially they present with fatigue, nausea, vomiting, they deteriorate rapidly and you can literally have multi-organ dysfunction. You can have renal failure, you have liver failure, you can have hepatic encephalopathy, you can have bleeding diastasis. Okay, and finally you can also have superadded sepsis and septic shock, right? So these patients have to be monitored in the ICU and the cause has to be identified adequately. So when you do the lab test, when the patient presents to you to the emergency, the first lab test is your arterial blood gas analysis. So what will you find in that? Liver failure plus renal failure. So you will have severe metabolic acidosis. You will have severe metabolic acidosis. Apart from that, very, very importantly, the lactate levels will be elevated because the lactate undergoes metabolism in the liver. Liver is not functioning. So you have elevated lactates. Apart from that, they can have hypoglycemia. They can have recurrent episodes of hypoglycemia. Okay. Then what about the serum electrolytes? You can have severe electrolyte derangement including hyperkalemia. Serum creatinine will be elevated. LFT. What happens in the LFT? The TBDB will be high. Yeah. But the AST ALT will be very, very high, very, very high, right? You can have it in 500, 600, 1000, okay? Then, what about the CBC? In CBC, you can find thrombocytopenia. You can have thrombocytopenia or decrease in platelet count. PT-INR APTT can be elevated or prolonged, right? So, this is how acute liver failure presents. Patient is extremely sick, right? Okay. So, how do you manage this patient of acute liver failure? So, in fulminant hepatitis, what do you do? Very importantly, you have to admit the patient to the ICU and counsel the attendants for a poor prognosis, right? So, many a times there are various ways in which it can present. So, first thing is you have to stabilize the patient. Second, most importantly, you have to find out the cause, right? So, you admit the patient to the ICU, right? You counsel the attenders about the prognosis. So, you have to take care of the hemodynamics. These patients are very, very sick. They can be in shock. So, you will have to provide them with adequate IV fluids. You watch for hypoglycemia. But since they have a concomitant renal failure, there is only a certain amount of fluids that you can give. If the BP does not improve even with IV fluids, you will have to put them on an inotropic support. Now, because of the severe metabolic acidosis as well as the elevated lactates and ensuing renal failure, you may have to dialyze them. You may have to initiate the patient on dialysis. Okay. Then you have to start the patient on anti-hepatic encephalopathy measures, including your lactulose. Okay. So, you put them on anti-hepatic encephalopathy measures, including your lactulose. Apart from that, you have to start them on broad spectrum antibiotics. Okay, because they are prone to sepsis, you start them on broad spectrum antibiotics. Apart from that, they may also have certain bleeding complications. They may have severe thrombocytopenia, elevated PT-INR APTT. You may have to transfuse them with blood products, including your FFP, which is a fresh frozen plasma, or you may also have to transfuse them platelets if they have severe bleeding and severe thrombocytopenia. Okay, fine. After all of this is done, you have to try and identify the underlying cause. Sometimes the cause is very, very apparent, right? So, the patient comes with paracetamol poisoning. Paracetamol poisoning, what is the drug of choice? It is N-acetylcysteine. N-acetylcysteine is your antidote for paracetamol poisoning. Similarly, if they have come with phosphorus poisoning, if they have come with rat poisoning, in rat poisoning, what you will do? You can do a plasma exchange. And help them improve. Though the outcomes are not that great, but you can still try for a plasma exchange. Okay. Then you have to evaluate them for the cause, for the underlying other causes, right? So, you will have to send for a complete viral panel. You will have to look for hepatitis B, C, E, what is the cause, right? You cannot check for the other viruses like CMV or HSV. So, but what you can do is you can do this much. Apart from that, you may have to look for the ceruloplasmin levels, see if this is Wilson's disease, look for autoimmune hepatitis, right? So, what is the cause, underlying cause? You have to find out and you can treat accordingly. So, in fact, there was one patient whom I recollect who had presented with fulminant hepatic failure. For him, we had not found any cause, and finally, we did a liver biopsy. So liver biopsy can help you establish the cause when there is no other cause that is found. And in the liver biopsy, you can find out certain other causes. So this is how you evaluate and treat your fulminant hepatitis. Okay, fine. Now, there are certain conditions where nothing works. Okay, the patient continues to deteriorate despite all of this. So that is when you use something called as your King's College criteria. So that is when you use something called as your King's College criteria, which is used for liver transplant. It is used for liver transplant. So finally, you have to refer the patient for liver transplant, right? So what is the King's College criteria? So in paracetamol poisoning, when do you refer the patient for liver transplant? If the PT-INR is more than 6.5, if there is a hepatic encephalopathy of grade 3 or 4, elevated creatinine more than 3.4 mg per deciliter, or the pH has been less than 7.25 for more than a day. So then you preemptively refer the patient for transplant. In non-paracetamol cases, in non-PCT liver failure cases, then if the INR is more than 6.5 and any three of the following are satisfied: age less than 11 years or more than 40 years, non-A, non-B hepatitis or drug-induced liver failure, time from jaundice to encephalopathy has been more than 7 days, INR more than 3.5 and bilirubin more than 15. If any three of the following are present, then you refer the patient for transplant. Okay. So this is about your fulminant hepatitis management. So we have learnt about acute hepatitis, the causes, we have learnt about drug-induced liver injury, and we have learnt about fulminant hepatitis. Thank you.